Presentation. We can't hear you.
Back to the beginning.
Okay. All right, so I'll be taking question number 3 of the May 2023 General Medicine Practice Questions, Part 2. And the question says 3A, define health education. 2, what are the importance of health education? 3, what are the barriers to health education? Then 3B says, the scenario of a man with oculocutaneous albinism. The patient came to clinic with an erythematous lesion on the right forearm. How would you educate him about his condition and what to avoid? Okay, so by way of definition, health education can be defined as the process of communicating health information to people aimed at encouraging them, 1, to want to be healthy, to know how to stay healthy, to know what they can individually and collectively do to stay healthy, and to seek help when needed. This is according to the Alma Ata Declaration. And then, but currently, WHO defines health education as any combination of learning experience designed to help individuals and communities improve their health and well-being by increasing their knowledge of and influencing their attitude towards a healthy living. What are the importance of health education? They include 1, to improve the health status of individuals, families, and communities. The next is to enhance quality of life, and then to reduce the incidence of premature death. And also, it significantly reduces the cost of healthcare as diseases are mostly prevented and when present, promptly diagnosed and appropriately managed. If I should explain this point, you know that a good number of our patients would have saved a lot of costs if they had come earlier, if they had known what they should do to prevent, or at least to present early once the symptoms begin. So this health education is very important to help minimize the cost of healthcare. And also it encourages health promoting behaviors among people. And then it increases the awareness of an increase of use of available health services. Sometimes individuals do not know that there are available health services that they could make you take advantage of within their community. So this health education helps to increase that awareness. The next question says, what are the barriers to health education? And the barriers include 1, lack of understanding of principles of adult learning, what we call the andragogy. The other side of it is pedagogy for pediatrics. But basically what this one is talking about is the fact that there are things to bear in mind when trying to communicate health education to an adult, and they include the fact that adults are autonomous and self-directed. So you should get them to agree with you in what you are communicating with them so that they can willingly on their own begin to practice what you are saying. Secondly, we need to bear in mind that they learn from previous experiences. So sometimes people are forged by what they've experienced before or what they've heard others experience. So you need to explain, take time to handle that as you're educating them. Thirdly, you need to bear in mind that adults are goal-oriented. So you should point to them what they hope to, what they expect to gain if they should follow what you're teaching them. And then there's also the awareness of the adult's need. Adults need to be shown respect. So in communicating to an adult, you need to add respect to what you're doing. And then adults need motivation to learn. And then lastly, adults are practical, focusing on the aspects most useful to them. So these are challenges that if a doctor does not understand these principles, they will lack the ability to communicate learning to an adult. Other barriers to health education include low health literacy level among the population, and also there is this language or cultural barriers where people believe that this is how we do it in our village. And even though the cultural practice is impacting negatively on their health, they want to stick to it because they believe that this is what they should do. So you need to go a long way to break that cultural barrier. And also poor economic condition. Of course, when you're telling somebody once you this, do this, come to hospital, the patient doesn't have money. They can't really obey what you're saying because you won't pay for them if they come. There is a place for the proliferation of unlicensed and uncensored trado-herbal medicine sellers. This is a major challenge to health education because in my own area, you have people that will mount loudspeakers on top of buses and go to communities and hamlets and teach them about staphylococcus and gonococcus, and then there is this one bottle that has the ability to cure all manner of diseases, you know. And they are doing these things without anybody controlling them. And people take health knowledge from them. And of course, after a while, you start seeing them presenting with acute kidney injury or even end-stage renal disease. Of course, there's also a challenge about the limited time for patient-doctor contact. All of us have experienced this. You have a patient, you really want to take time to teach what the patient needs to know, but then you're rushing because you have like 20 more persons lined out outside waiting for you to see in the clinic. That can be a limitation. Also, you have a limitation of limited knowledge or confidence by the healthcare personnel. So when the doctor, the nurse, or whoever doesn't really understand what the disease is all about, the patient is asking questions, they may not really be able to communicate adequate knowledge to the patient. So that can be a barrier. And then lastly, I'll be talking about the patient's physical disability. So you have a patient that has hearing impairment or visual impairment. It's really difficult to get them to understand what you are communicating. And also in our environment, I didn't add it here, but sometimes religious beliefs can be a major barrier because you are telling someone that you need this medication, you need to do this, and they'll tell you, I believe that I've been healed. Even though we know God can heal, but at least you could let the doctor, you could let God use the doctor to heal. But sometimes their strong belief in religious practice can really limit their acceptance of this health education. Okay, so a further expansion of the topic, I want to look at steps in patient education. So if you want to really educate a patient, you want to bear in mind the following things. Firstly, you want to assess learning needs. Okay, well, what the patient really needs, because it's not everything in medicine you're going to be talking to the patient about. I once had a patient that was complaining of poor asthma control, and I've done everything, maximized my medications, and it wasn't really responding. So I asked the patient to show me how he uses his inhaler, so that I'll be sure. And he opened the inhaler and stuck it into his nostrils and tried to puff it into his nose. And I realized that my patient was far behind understanding what we're talking about. I had to start from teaching basic inhaler technique before we start talking about whether patient is responding or not. So assessing patient's learning need is very important. Then also you have the place for developing learning objectives. So you want to know what do I need to communicate to the patient. Then you plan on how to implement this patient education. Then the fourth point is that there's a place for teaching methods or implementing patient education. So several patients need different methods. Sometimes you need practical or audiovisual aids to help them to really understand this. Okay, there's a place for teaching materials used in implementing patient education. Sometimes you could just share with them a short video clip that can help them understand what they need to do. Then there's a place for evaluating patient education. So you want to check whether the patient is understanding what you've been teaching, what you've been communicating. So you ask them back the questions and see what they will respond, how they'll respond, sorry. Then lastly, you have a place for documenting patient education and learning. So at this point, you're trying to say that, I taught you this, and then you want to document the fact that patient had been taught or been educated or informed. Okay, so having taught the patient, you want to ensure that learning has taken place. What do? There's a place for reinforcement, and in reinforcement, you ask the patient to repeat what you've taught the person to see how, in this case, you repeat what you taught the person in a different way, okay, so that you'll be sure that what you taught has been reinforced. Then the place for retention is where you ask the patient to now repeat what you've taught him or her to see whether they really got what you said. Okay, there's a place for motivation where you give the patient beneficial reasons to adhere. And you're like, if you do this and do this, this is the benefit, this is how it will impact positively on your health. And then you see that patients are motivated to go ahead. And then there's a place for transference. At this level, you are trying to make sure that the patient has turned over his or her interest and focus from whoever he has been listening to or whatever he has been focusing on to you and what you are teaching him. So the patient shows interest and willingness to receive the point you are laying out. So that's the much I will be talking about on health education. Then the B part of the question says, as a scenario of a man with oculocutaneous albinism, and is a patient came to clinic with an erythematous lesion on the right forearm. Then they say, how would you educate him about his condition and what to avoid? Okay, so in doing this, I would like to explain to the patient what albinism is all about and the clinical forms of albinism. And I also talk about the possible complications and then how to prevent and manage them. And then also, I will emphasize on social support and motivation, which these individuals really need. So albinism is actually an inherited abnormality of melanin synthesis. Melanin is produced from tyrosine. So any abnormality that is inherited that leads to impaired production of melanin, it leads to albinism. Okay, and this condition leads to congenital reduction or absence of these melanin pigments. Now, melanin is a photoprotective pigment in the skin that absorbs ultraviolet light from the sun, thereby preventing skin damage. Of course, melanin is produced by the melanocytes in the skin. And also, the lack of this melanin exposes the patient's skin to photosensitivity and then sunburn, and also increases the risk of skin cancer. In the eye, melanin plays a role. There are melanocytes in the pigmented retinal iris and ciliary epithelium, and these melanocytes produce melanin. Now, melanin is very important in development of the fovea, which is a part of the retina that enhances the focusing of light to produce sharp images. Okay, and also melanin is very essential in the development of the neural connection between the retina and the brain. So once you have a deficiency of this melanin, this development of the parts of the eye is impaired, and so vision is also impaired. So that's basically what happens in oculocutaneous albinism. Okay, so epidemiology, there is about 1 in 17,000 in USA, and the global prevalence of 1 per 15,000. Now, oculocutaneous albinism precisely, especially the type 2, is the most common, particularly the type 2, OCA2, is the most common type of albinism generally, okay? And it occurs most commonly among the Afro-Americans and the Africans, with an estimated frequency of 1 in 10,000, when compared to that of 1 in 36,000 for the whites. And generally, there is equal male-female distribution for albinism generally, except for the ocular albinism with the OA type 1, okay, which is X-linked recessive, where males are affected while the females are only carriers. Okay, so the forms of albinism, there are 2 major types. You have the oculocutaneous albinism, which has 7 subtypes, but we're going to focus on about 3 here, while you also have what we call the ocular albinism, which has 2 major subtypes. We're going to see that shortly. So the oculocutaneous albinism, these have 7 subtypes according to genetic abnormalities, and they are all inherited as autosomal recessive. Okay, so the first type is the OCA1, so which has type 1A and 1B. Okay, now this results due to mutation in chromosome 11, the long arm of chromosome 11, section 14 to 21, and it involves the impairment or development of a tyrosinase enzyme, which
hello? Hello?
Yeah. Hello?
Are you sure that giving us a lecture on albinism is part of this question?
Actually, sir, I wasn't sure how I'm going to do it, whether to just, because I wasn't sure whether it's like a session.
Dr. Obi, Dr. Obi,
So
this
you need to read
is
the question again and understand what the question is and try to answer it, okay? Just go back to the question, read what we are asked to do. You know all this stuff, that's fine, but just read the question and then try to see if you can answer it. Just go back and read the question.
Chief Amigos, we don't have time today to beat around the bush. It's a counseling station. You're supposed to counsel somebody that is living with albinism. So you completely missed that. So in 5 minutes, you just have to do that so that we'll take the next 2 presentations. As I usually say, if you have any challenges, reach out to us. If you don't understand a question, that's why we have a lot of facilitators in the group. Always reach out to someone that, please, I don't understand this. Can you enlighten me to help you?
So you can see the question. The question says, how would you educate him about his condition and what to avoid? It's a straightforward question. So try to answer that in 5 minutes.
Okay, I've already mentioned, okay, let me start afresh. To educate this person, I would like to, okay, let me assume I'm talking to somebody now. Okay.
Dr. Atta, Dr. Atta, he can cancel you just to save time.
Yeah. Okay.
Okay, good morning, sir.
Good morning.
My name is Dr. and I've been asked to counsel you about your condition of albinism. I understand your name is, please, may I know your name?
Okay, my name is Zata.
Okay. Now, the condition you have is known as albinism, and the particular type you have is what we call the oculocutaneous albinism. And what this means basically is the fact that there are chemicals that are produced in the body, especially in the skin and also in the eyes. These chemicals are called melanin. And what they do in the skin is that they prevent the damage of sunlight to the skin. So they act as a protective barrier to sunlight damage, ultraviolet light from the sun to your skin. And also in the eyes, they also help in the development of parts of the eyes that help you to see very clearly. Now, we found that in some individuals, these pigments, these chemicals called melanin, which are produced by a particular type of cell, are deficient. Their production is impaired. Okay, and when their production is impaired, the patient will have skin that is very white because these pigments produce a dark coloration of the skin, especially when the sun rays are active. So that challenge is what we found out in you. And how it happens is that it is inherited. Okay, so it's not like you did anything that led to it. It's inherited, and it's inherited in a format that is we call it autosomal recessive. What that means is that if your parents are carriers of the gene, okay, the father, the mother, they are carriers of the gene, there is a 1 in 4 chance. There is a 1 in 4 chance that each of their child will have this condition. Okay, and we've known that some of the complications that results from this disease include this condition, skin condition includes some kind of skin burn that could present like this erythematous lesion you have. And then sometimes also they can also develop skin cancer. Okay, but this one you presented with this erythematous lesion, we are not sure what it is. So we may still have to refer you to a dermatologist where you will be properly examined and probably a skin biopsy will be taken, okay, to be sure what kind of lesion it is and then the best treatment to offer you. Okay, now you also know that they can also affect the vision. So, and the patient will be able, you may notice that you've not been able to see visions clearly, or sometimes your eyes move in 2 directions in a very rapid manner, and that might impair your vision. However, we want to just say that there are things you can do to avoid some of the complications of this condition. And concerning your skin, some of the things you need to know is that you should minimize as much as possible, avoid exposing your skin directly to sunlight. To do this, you may want to minimize the number of times you expose directly to sunlight, or you may wear some protective clothing that are soft and they absorb the heat from the sun. Also, you may want to apply a kind of cream that is a sun protective cream that has a power of up to 30. So what's called SPF 30, sun protective factor 30. So there are creams like that we can give to you. When you apply them, they forms like a coat over your skin and prevents excessive impact of the sun rays on your skin. Okay. Then you can also, because this condition can make you, when you come out in sunlight, you can't really open your eyes very clearly to see because of the you are excessively sensitive to bright sunlight. So to avoid this, you can wear eyeglasses that are sunshades. Also, you can wear head cap or hats that have a wide rim so that they can cover your eyes from excessive rays of the sun. Okay, so you can also use umbrellas whenever you are out there under the sun to prevent this excessive impact of sunlight. And then also, once you notice any lesion, you should also always be inspecting your skin every other day, so that once you notice any skin lesion, don't take it for granted, present immediately, so that it can be properly inspected and to be sure that it is not something cancerous or dangerous that can harm you. Then concerning the eye challenges that come with this condition, you should be able to, you should seek the help of ophthalmologists who will inspect your eyes, and maybe if there is short-sightedness or long-sightedness, maybe you find it difficult seeing objects that are far or objects that are near, you can be given eyeglasses that will correct this. Okay, other conditions like astigmatism or conditions whereby you have your eyes moving rapidly, they can give other eyeglasses that can cover it. And in some rare cases, some surgical intervention can be used, to help you in this condition. And then also other things that can be done for your visual impairment is that you can use materials with books that have very large prints, or you can use the handheld lenses that can help you magnify whatever you want to read so that you can see it more clearly. So these are some of the things you can do to help you. Then I would also want to say that people in your condition, sometimes they suffer stigmatization in the society. So I would also want to connect you to some support group of people with the same condition who have learned how to manage it, and you can also learn from them, their experiences, and also get support and share your challenges so that we can also help you. So this is the much I can explain for now. If you have any question, I would like to answer it, or any other challenges you're having, I would like to hear you now and explain further. Thank you, sir.
Okay, thank you. Thank you for the plenty information. But doctor, most of the things you said, I've forgotten most of them because I'm not too comfortable. I don't understand what you just finished, telling me now. You were saying some things. I just came with rash on my right arm. So this rash has been there for some time now. So I don't know, what did you say I'm going to do again? Because I don't understand what you were saying.
Okay. Actually, I had explained a whole lot of things for you, and I had said earlier concerning the rash on your hand that we are going to seek the assistance of a dermatologist so that it can be inspected thoroughly, and probably.
So who is the dermatologist?
Okay, it's another area of specialists under our care, under our department or units, who are specialized in looking at people's skin, and they check whether any abnormalities in the skin. So they're like skin care specialists. So they will look at this skin and see if they may need to take a tiny pinch of that particular area where you have the lesion to go and check it under the microscope in the lab to see whether there is what exactly is wrong with your skin and the best way to treat it. Did you understand what I explained?
Okay, so there are people that will look at it and then they'll treat me.
Exactly. But then I will
Okay.
continue to have continuous counseling sessions with you to further explain what I have already told you, because there's so much for you to know in a short time. But if you have any other concern, maybe stigmatization or how you inherited this, you can ask me and I will explain.
Okay. Well, for time's sake, so probably we'll just give room for comments so that we'll take it as together, so that we can round up this session and go to the next question. So the class is open. Yes, ma'am.
Because of time.
Yes.
Chief sir. Because of time, Dr. Fatima,
Hello?
Chief Remigri, to get the facilitator just coming in round up.
All right. Yes, Dr. Christopher, good morning, Dr. Atta, good morning. For the interest of time. Just to point out to the speaker, you have a lot of information. That is the truth. And that means that you have done your research on the subject matter, or you've done your reading on the subject matter of albinism. But this question, and you should always note that in every question, there are two things you need to understand. One, what is the scenario telling me about? Okay. And two, what is the task that has been handed over to me? Do you understand?
Yes, sir.
For instance, the question we took yesterday, the second question, the one on the patient with the renal impairment. Okay. For instance, now it was pointed out to me later that the creatinine what the patient was given. Okay. And they said initially the creatinine was normal. So that could suggest the presence of an AKI. But with that without that information, okay, then you cannot say that this is a patient with an AKI. Okay, so you need to understand the scenario of the question. Okay, so like when yesterday I said, oh, this may not be an AKI. Okay, with that extra information, now it can suggest that the patient has an AKI. So it's important for you to understand the question or to understand what has been put in front of you. Secondly, it's the task. The task is on patient education or health education, as the case may be, and how you want to say it. Okay, and if you're educating a patient, okay, one thing is key. You need to understand what's language. You need to ask the person if the language you are speaking is the language he's conversant with, so that he can understand your explanation. Okay. For instance, you can be talking to the person and say, oh, I'm going to speak in English. Are you okay with explanations in English? The person could tell you, please, no, I would rather broken English. Or even like where I am, in Ogbomoso, most patients will say, please, say it in Yoruba. Do you understand? So
Yes,
you
sir.
first have to understand the language of the patient. Two, you have to understand the educational status of the patient. Is it somebody? So if this person says, I understand English, but his level of education is primary of, early secondary, for instance. Okay, there are some kind of words that when you say, the person may not get it. So you have to tone down what you say a bit, right? Now, when you're educating a patient and you tone down the language, you have to explain things with things that the person understands. Okay, so that's why sometimes it's so good to know what the person does for a living and things like that. So you can relate it with what the person understands. Now, you did a good job by saying yes, because that covering is not there and you're exposed to the sun. But there are a lot of terms you put inside there that the person will not be able to follow. Excuse me. Okay. Now, also, it's important that, sorry, I have a cold. Okay. It's also important that when you're explaining to the person, you pause in between to be sure that the person understands. You make statements like, oh, do you understand? Oh, can you go over it again? Okay. Oh, would you want me to say it again? Or would you want me to explain this again? So you have to ensure that when you're communicating, you're getting feedback. Do you understand? There is no
Yes, sir.
way you've transmitted an information that you must not test whether the receiver has received it and received it appropriately, and he has not misconstrued it or mixed it up. Do you understand? So you have to slow down and give information in tidbits, and then find out if the person understands that information that has been handed over. Okay. All right. So I think those are the major things that I would want to point out that we need to perhaps take into consideration when you're educating a patient. And always know that you may not be able to finish all the education at once. Okay, so you set out time to also give the person, okay, we can go over it again some other time, or when we meet at social time, we can see this. Oh, I'm going to actually see this particular doctor. Please never call a doctor by their specialty. Just say what the doctor does for a living. Oh, I'm going to forward you to a doctor that specializes in dealing with this type of condition. You don't have to mention that it's a dermatologist or it's a gastroenterologist or whatever you're going to see. No, you don't have to. Or you have simply say, oh, I'm going to hand you over to someone that specializes in this particular experiences or this particular type of. Oh, okay.
Okay, sir. Thank you, sir.
Okay. All right. So those are just my submission. Thank you.
Yeah, thank you very much, sir.
Yes.
Any other comments from our teachers before we move?
Okay, now any comments now?
Hello?
Hello, Chief Remy. Good. Go ahead, sir.
Yeah, all right. Thank you so much. So, Dr. Day, first of all, I must commend you. Thank you for taking up the question. I know it was a question that was meant for someone else to answer, and then we kind of co-opted you into answering it. And I'm actually happy you did. I'm sure you also be happy that you did.
Yes, I
Because
am.
the truth is, yeah, you had so much information. It was obvious you did your research, and then, but now you now see how you are supposed to answer the question. So please always remember that the question is key. You must understand the question. If you don't understand the question, you are not likely to get the answer. So that's usually the key thing. Just as Chief Shito has said, the first question you should ask yourself is, what exactly do they want me to do here? Now, if you're able to answer that question, you're more likely to get the answer right. You may have all the information, but if you don't understand the question, you will not get the answer right. Okay? So, like the issue of when you are now actually educating the patient, it was obvious to me that even though you had all the stuff, you were not applying them. On your slides, we saw the place where you have to assess how well the person has gotten your information, but you were not doing it when you were educating the patient. You understand? Okay, so fine, it's okay to have all those information, but the important thing is applying it, and that was what that second part of the question was trying to do. Now that you know how to educate, health educate, can you apply it in a real life scenario? Okay, and this your simulator, the guy, the harsh guy, the way, the way, the way he finished you, to say, everything you have been saying, I did not even understand anyone. It's because you did not tell him to recap. You didn't try to pause to see if he has retained the information you are giving him. And it's in that your slide. There's a place talked about retention. Okay. So I think the major message here is that understanding the question is key. And then in this kind of situations, you must always be sure that the patient you are carrying the patient along. You might have so much information, but if you're not passing it across, then you have not answered the question. In fact, if you don't have much information and you're able to pass across the little one you have, you might get more marks than someone who had all the information but was not able to pass it across. Do you understand? Okay. So the key thing here is be able to educate the patient, to communicate with the patient. Communication is key. Thank you.
Okay,
Chief
thank you very
Remy.
much, sir.
Thank you so much. Dr. Maduka, can you start sharing your slides? Any other
Okay, Chief.
comment from our facilitators? Why you share your slide? Dr. Ude, thank you so much. We appreciate your time. Thank you so much. Thank you. Just a brief comment. As I said earlier, when we reached out to the person I supposed to answer this question yesterday, there was an emergency. So quickly reached out to this doctor who gladly volunteered. So please, this is a discussion. And with few hours, he already gotten a slide ready, and this is the spirit we talk about every day. So I must really commend Dr. Maduka for his effort, really. Thank you so much. I appreciate you. Well done. So Dr. Maduka, you can go ahead. This is a discussion, please.
Thank you, Chief. Good morning, everyone. Good morning, my teachers and colleagues present. Can I be heard?
You can be heard.
Can
Go
I
ahead.
be heard?
Yeah,
Okay.
you can be heard.
Good morning, everyone. I'll be attempting this question number 8. The question says, you are the new head of a 75-bedded stroke ward with 1 neurologist, 2 physicians, 5 nurses, 3 porters, 2 physiotherapists. Outcome of stroke in the ward has been reported to be poor. So the questions include: 1, define clinical governance; 2, list the pillars of clinical governance; and then 3, use any 3 pillars to address the problems above. And for each of the pillars, give the definition and list the components of the pillars. So we define clinical governance as a system through which organizations are accountable for continuously improving the quality of their services, safeguarding high standard of care, and minimizing risk by creating an environment in which clinical excellence will flourish. It can also be defined as the systematic approach to maintaining and improving the quality and safety of patient care, the framework through which healthcare organizations are accountable for continuously improving the quality of their services and safeguarding high quality of care. So the next question said that we should list the pillars of clinical governance. So there are 7 pillars of clinical governance, and they include risk management, education and training, clinical audit, clinical effectiveness, staff management, information, patient and public involvement. Now, this is a new, the recent update. This is the pillars that they gave, but I found out that the previous updates had almost the same, but I think the nomenclature was different, and they used a mnemonic record where R is the risk management, then E, education and training, clinical audit, clinical effectiveness. Then the O in the record is openness, teamwork, and communication, which I think will fit into the staff management. Then the R there was research, and then D was development. So I think if you look closely, it was a matter of nomenclature. It can be interchanged. So going straight to the third question, it says that we should use any 3 pillars to address the problems above, and for each of the pillars, give the definition and list the components of the pillars. Now, looking at the question, the first thing I will want to do is to establish an audit, a clinical audit committee. So this clinical audit committee, basically what they will have to do, it will have to do with quality assessment of what has been happening in the stroke unit or stroke ward. And then based on whatever they find out, which if you look at the question closely, it appears as though they are understaffed. So staff management will come in. And then after the clinical audit and staff management, we can be able to set up standards for effective clinical effectiveness and research. So I want to use these 3 pillars to solve this problem. So clinical audit, like I said earlier, basically has to do with quality assessment. So clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria. So basically you assess the quality of what is happening in the stroke ward or stroke unit, and you can be able to compare it with international best practices. And with that, you can offer solutions to the problems that could be identified. And usually where indicated, changes are implemented and further monitoring is used to confirm improvement in healthcare delivery. So this clinical audit may also involve risk assessment by the committee that are involved, which will also have to do with identifying the risks, assessing the risks, and ways to control these risks. And the components of clinical audit will include to prepare and plan for carrying out the clinical audits by the people involved in the committee. And then, like I said earlier, a selected standard criteria will be found, especially in this case, being a stroke unit or a stroke ward. So the committee will have to find out the international best practices for setting up a stroke ward and how it is managed and the equipment that are needed and the manpower that is required. Example, doctor to patient ratio. As you can see from the question, there is only one neurologist in a 75-bedded stroke ward, and I think that should be that will be deficient. So in once they find out about the international standard best practices, which they will use as their standard criteria, they will now try to measure the performance of what happens in the stroke unit, how everything is being carried out, and then further improve, trying to, when they find out what goes around there, they can now give advices as to how the stroke units and the activities that go on there can be improved, and by so doing also offer information that can help sustain whatever improvement that will be made. Now, from the stroke unit, the clinical audit committee haven't looked at what happens in the unit. One of the obvious problems that will be identified will have to be do with the staff and staff strength. So this is where staff management now comes in. And this staff management has to do with openness, teamwork, and communication between members of staff. And so staff management ensures correct staff are employed for the correct jobs. And then any staffing issues, in this case, the staff strength, will be addressed. And then the staffs will be encouraged to actively participate in progress being made in the stroke unit or stroke ward. So additionally, it requires the employer to provide an open attitude with good working conditions and appropriate management of staff members. And this staffing that I talked about, of course, has to do with teamwork. So there's a neurologist, there's a physician, and then there are nurses. So I just wanted to just put out that a team is a group of people with complementary skills, knowledge, and expertise that is organized to work together towards a common goal. Now, having established having done the quality assessment by the clinical audit committee and probably identifying some of the weaknesses or some of the reasons why there is poor outcome in the unit. So the next thing to do will be to set up a kind of standard for clinical effectiveness and research, which has to do with ensuring the use of the best available evidence and research to provide the best possible outcome. So, like I said earlier, it's basically about finding out what is acceptable or guidelines that have been laid towards providing this service towards providing it as in services in stroke wards or establishing a stroke unit, comparing it with what is obtainable in my center, and then offering solutions based on the problems that have been pointed out, and then the international best practices. For instance, establishing criteria for admitting a patient into the stroke ward in the first place, where some parameters could be applied to ensure that patients with chances of benefiting from the facility are admitted, and not just everyone, especially those with prognosis that are abysmally poor and probably have very slim or no chance of benefiting from being admitted into the stroke ward. So with this, you can establish some guidelines or some criteria. For instance, we can use the Glasgow Coma score or any other score used to assess the severity of stroke in a patient, so that if we have a patient and probably the patient has little or no chance of pulling through, so we could step down admitting the patient into the stroke ward, rather and rather admit people that stand great chance of benefiting from the facility. So this is one of the ways that reducing the outcome, reducing the poor outcome that has been noticed in the facility can be taken care of, in addition to staff strength. So that's what I was able to find out, and I will welcome questions and some contributions. Thank you very much.
Okay, thank you very much, Dr. Maduka, for a wonderful presentation at a short notice. So we welcome comments and contributions. Any comments, any contributions?
Keep cooking, ma. She's a queen of clinical audit. Any comments, ma?
Yeah, good morning, Dr. Christabel. Good morning, everyone. Please, can you hear me?
Yes, I can.
Okay. Sorry, I had a bit of divided attention, this morning, but I kind of got the meat of the discussion, and I think the presenter did a wonderful job, and just as an overview, clinical audit is an integral part of the national postgraduate exams, and is one question that you cannot avoid. One specialty will set a question on clinical audit, and it's always an applied question. So the understanding of the basics of clinical audit, vis-a-vis the steps which she mentioned, and which is different from the components, where we have the structure, the process, and the outcome. So understanding each of these and applying it to the question at hand is important. So what you should understand about clinical audit is that it is a continuous cycle. So it seeks to improve your current practice to be in line with the international best practice for that disease condition. So at every time, achieving excellence is your watchword. And it's not something that can be solved in a single cycle. And that's why whenever you are conducting a clinical audit, you must have an objective. And your objectives must be SMART. That is using the acronym, which we all know. And you should, so because your objective is specific, you can't handle too many things at the same time. So it's either you are auditing the structure, which involves the materials, money, and manpower on ground, or you are auditing the process, which involves the behavior, the knowledge, the behavior, the attitude of those who are providing healthcare, or you are auditing the outcome, which involves, the things that you are seeing on ground, in terms of what is the outcome from what the clinical health providers are providing on ground. So when you look at clinical audits in this aspect, you now choose which of these will best answer your question at that time. And you go out, do your research, find out, create a team, and your team must be all inclusive. So just as teamwork will tell you that people with complementary skills, and expertise coming together, for a common goal. So your team has to have a variety of staff. So not just only doctors, you will have nurses, you will have pharmacists, and also the patients is also an integral part. So you look at it in the terms of those who provide care, those who receive care, and those who have the authority to implement, because there must be a backing, for your clinical audits to be effective. So if you do not involve the hospital management, you cannot get a desired outcome, because it's the DCST or CMAC in some balances, or the CMD that would more or less sign whatever you've done into law and come up with a guideline and say, and disseminate it to the hospital for everybody, for all staff to follow. Condition in managing that or improving that service, So those three cadre of people, with all the people who make up that, should be involved, and thereafter you select your standard practice, which is also a very important thing. So most times we follow international guidelines, and then you could also follow local, if it has to do with maybe some hospitals around, and then you have very good local guidelines too, that can stand as your standard practice. Then, of course, you have to measure performance. So if you don't know where you are, you don't know where you're going to. So you need to find out what are the things on ground. So if you are going with structure, auditing in line of structure, you need to know your staff strength, you need to know your equipment that you have, you need to know your space, you need to know your structure, you need to know all those things. What do you have on ground, and then if you are assessing the process, you need to, know what the staff know, regarding that condition. So you do this with the aid of questionnaires and proformas, to gather information. So that helps you to measure your performance on ground. And then thereafter, you would analyze that, and then you would now apply what you have with the international best practice and try to see where you are coming short, you are falling short of. And you would now, teach all the people that are involved and, gather that information, because this is what you would present to the management to convince them to, either employ more staff or provide more beds or provide more equipment, or send the staff for training, or retraining, as the case may be, and then you give a time. Remember, your objectives are SMART. You give a time where these improvements you've done, or these changes you've taken out will be carried out. And then at the end of that time, you would carry out another audit to see if there has been improvements in your quality of services. And this runs for a particular time until you are ready to carry out another audit, to see why you have still not gotten to, the 100% that is, acceptable for that condition. So that's, or for that practice. So that's how clinical audit runs. So it's a continuous cycle. At each time you want to, assess what you have on ground and ensuring that you are offering the best. So I think I'll stop here and entertain any questions. Thank you.
Thank you very much.
Thank you.
Wonderful contribution. So any questions, any clarifications? Our time is fast spent, so we won't be able to take the last question from this series. But I'll hand over to Dr. Christabel now. Dr. Christabel.
Thank you, Dr. Atta. Thank you so much. Thank you, everyone. So thank the two presenters today. These are volunteers and they put in their best. So thank you, Dr. Ode. Thank you, Dr. Maduka. We appreciate you. Thank you so much. The participants, thank you. And our chiefs for fine-tuning the discussion, Chief Chito, Chief Koke, all our other fellows present in the house. Thank you for coming to class. Chief Kukima, then Dr. Kopi, Dr. Kopi first, and Chief Chito, Chief Cookie, just a word for the class and we'll close the class.
Okay, thank you very much, Dr. Christabel, and thank you to the presenters. I was just made aware that, your presentation was just given to you at short notice, and you came up with, very good and robust discussion. So I want to encourage us all because, since we are practicing, that's why we get to get the question way ahead of time. But in the exam, you don't have that luxury. So the questions are set. You will just see them for the first time in the exam hall. So if your reaction time is not fast, unfortunately, you can fail that station. So it's good that we are also putting you on your toes. And for those who volunteered, God will bless you, And I believe that this would not go unrewarded, So I want to encourage each and everyone. Amen. Thanks. I want to encourage each and every one of us. Please, let's own this class. Let's be participants. Let's, really work because you would never know what you know and what you don't know if you do not talk and participate. So I just want to just say a word to the person who had a counseling station. Don't ever forget the spikes. The spikes model is very apt. And as I said, always read the question and understand the task, because you still need to, over the setting, get a mini biodata, and most especially the educational level and the occupation of these patients, because it may be part of the consents, you know, because when it comes to impacting knowledge, especially for that case that we're talking about albinism, you know, prevention is key. If you're talking to an albino, you don't talk about sunscreen, you don't talk about sun avoidance, you know, you don't talk about, you know, looking at your skin, taking care of your skin, and then knowing the occupation. If the occupation is a risk to that patient, I think you would miss the marks in that station, because that is usually the catch in that station. So it's not enough to go telling them it's tyrosine deficiency. That's big stuff. Just say it's a genetic condition, and then the person may even be worried. What if I get married? You know, will I have children that have this condition? So all those things are usually the questions that come with such genetic conditions. So you must, you know, give time to understand the perception of this patient, their insights, their concerns, their expectations. So that would also guide you when you are imparting knowledge, you know, and then of course that empathy must show through in everything you're saying. And then the summary, and also giving them materials to study more, and then also for follow-up clinic visits. So if you don't cover all these bases, I don't think you've done justice to any counseling station. So I want to wish us all a very beautiful day and a very wonderful Valentine's. I love you all. Good morning.
Happy Valentine, everybody. Love is in the air.
Love is in the air.
Thank you so much, Ma. Thank you.
Thank you very much.
Said something. So, Kopi, do you want us to say something? That's all Kopi said. Anyway, thank you. Thank you, participants. We appreciate your presence. Please don't present it tomorrow. Don't answer the next West Africa questions. Please, we are doing chronological. Number 1, number 2. 1A, 1B. Please, let us not look for you tomorrow. Please, let us not look for you tomorrow. So if they are not in class, if you have people that are your friends that are presenting tomorrow, please send them a reminder. Please, so that there will be no break in